Hi everyone, welcome back to my YouTube channel. In today's video, I will be talking about CMS proposed rule for fiscal year 2024 hospital inpatient prospective payment system and long-term care hospital prospective payment system. Let's dive right in. On April 10, 2023, the Centers for Medicare and Medicaid Services or CMS issued the fiscal year 2024 Medicare Hospital Inpatient Prospective Payment System and Long-Term Care Hospital Prospective Payment System proposed rule. The proposed rule would update Medicare fee-for-service payment rates and policies for inpatient hospitals and long-term care hospitals for fiscal year 2024. CMS is publishing this proposed rule to meet the legal requirements to update Medicare payment policies for inpatient prospective payment system hospitals and long-term care hospitals on an annual basis. This fact sheet discusses major provisions of the proposed rule, which can be downloaded from the Federal Register at the link that you are seeing on this slide. This link is also available in the description box down below. Background on the inpatient prospective payment system and long-term care hospital prospective payment system. CMS pays acute care hospitals, with a few exceptions specified in the law, for inpatient stays under the inpatient prospective payment system. Long-term care hospitals are paid under the long-term care hospital prospective payment system. Under these two payment systems, CMS sets base payment rates prospectively for inpatient stays, generally based on the patient's diagnosis, the services or treatment provided, and severity of illness. Subject to certain adjustments, a hospital receives a single payment for each case depending on the payment classification assigned at discharge. The classification systems are Medicare Severity Diagnosis Related Groups or MSDRGs in IPPS or Inpatient Prospective Payment System, and Medicare Severity Long-Term Care Diagnosis Related Groups or MS LTC DRGs in Long-Term Care Hospital Prospective Payment System. The law requires CMS to update payment rates for inpatient prospective payment system hospitals annually and to account for changes in the prices of goods and services used by these hospitals in treating Medicare patients, as well as for other factors. The index used to do this is known as the hospital market basket. The Inpatient Prospective Payment System or IPPS pays hospitals for services provided to Medicare beneficiaries using a national base payment rate adjusted for a number of factors that affect hospitals' costs, including the patient's condition and the cost of hospital labor in the hospital's geographic area. CMS updates long-term care hospitals' payment rates annually according to a separate market basket based on long-term care hospital specific goods and services. Changes to payment rates under inpatient prospective payment system. The proposed increase in operating payment rates for general acute care hospitals paid under the IPPS that successfully participate in the Hospital Inpatient Quality Reporting or IQR program and are meaningful electronic health record users is projected to be 2.8%. This reflects a projected fiscal year 2024 hospital market basket percentage increase of 3%, reduced by a 0.2 percentage point productivity adjustment. Hospitals may be subject to other payment adjustments under the inpatient prospective payment system, including payment reductions for access readmissions under the hospital readmission reduction program, payment reduction of 1% for the worst performing quartile under the hospital acquired condition or HAC reduction program, upward and downward adjustments under the hospital value-based purchasing or VBP program. The proposed increase in operating and capital inpatient prospective payment system payment rates will generally increase hospital payments in fiscal year 2024 by $3.3 billion. In addition, CMS projects Medicare disproportionate share hospital or DSH payments and Medicare uncompensated care payments combined will decrease in fiscal year 2024 by approximately $115 million, subject to determinations on applications for additional payments for inpatient cases involving new medical technologies. Following a review of public comments on the proposed rule, CMS also estimates that additional payments for inpatient cases involving new medical technologies will decrease by $460 million in fiscal year 2024, primarily driven by the expiration of new technology add-on payments for several technologies. Changes to payment rates under long-term care hospital prospective payment system. For fiscal year 2024, CMS expects the long-term care hospital standard payment rate to increase by 2.9% and long-term care hospital prospective payment system payments for discharges paid the long-term care hospital standard payment rate to decrease by approximately 2.5% or $59 million due primarily to a projected 4.7% decrease in high-cost outlier payments as a percentage of total long-term care hospital PPS standard federal payment rate payments. CMS is seeking comment on the methodology used to determine the long-term care hospital PPS outlier threshold for discharges paid the long-term care hospital standard federal payment rate. Safety Net Hospital request for information. CMS is working to advance health equity in the proposed rule through a focus on safety net hospitals. Safety net hospitals play a crucial role in the advancement of health equity by making essential services available to the uninsured, underinsured, and other populations that face barriers to accessing health care, including people from racial and ethnic minority groups, the LGBTQ+ community, rural communities, and members of other historically underserved groups. CMS is seeking public input on the unique challenges faced by safety net hospitals and the patients they serve and potential approaches to help safety net hospitals meet those challenges. Continuation of the low-wage hospital policy. CMS proposes to continue temporary policies finalized in the fiscal year 2020 Inpatient Prospective Payment System / Long-Term Care Hospital Prospective Payment System Final Rule to address wage index disparities affecting low-wage index hospitals, which includes many rural hospitals. As CMS only has limited data from the time period this policy has been in effect, CMS believes it is appropriate to propose continuing the policy while CMS obtains and reviews additional data. Rural Emergency Hospitals or REHs and Graduate Medical Education or GME. This rule also includes proposed changes to GME payments for training in the new Medicare provider type Rural Emergency Hospital, which was established by the Consolidated Appropriations Act of 2021 to address the growing concern over closures of rural hospitals. These changes, if finalized, would help support graduate medical training in rural areas by allowing these rural hospitals to serve as training sites for Medicare GME payment purposes after they become rural emergency hospitals. Health equity impacts. The rule also advances one of the goals of the CMS framework for health equity 2022 to 2032 to more explicitly measure the impact of CMS's policies on health equity. As part of CMS's growing capabilities in this area, CMS is proposing to add 15 new health equity hospital categorizations for the fiscal year 2024 Inpatient Prospective Payment System payment impacts. Moving forward, one of the priorities of the CMS framework for health equity 2022 to 2032 is to expand the collection, reporting, and analysis of standardized health equity data. As additional data become available, CMS plans to incorporate it on an ongoing basis into their impact analyses. Social determinants of health diagnosis or SDOH codes. Inpatient prospective payment system payment is made based on the use of hospital resources in the treatment of a patient's severity of illness, complexity of service, and/or consumption of resources. Generally, a higher severity level designation of a diagnosis code results in a higher payment to reflect the increased hospital resource use. After review of their data analysis of the impact on resource use generated using claims data, CMS is proposing to change the severity designation of the three ICD-10 CM diagnosis codes describing homelessness, example unspecified, sheltered and unsheltered, from non-complication or comorbidity or non-CC to complication or comorbidity or CC, based on the higher average resource cost of cases with these diagnosis codes compared to similar cases without these codes. Changes to the new COVID-19 treatments add-on payment or NCTAP. In response to the COVID-19 public health emergency, CMS established the new COVID-19 treatments add-on payment or NCTAP for eligible discharges during the public health emergency. In the fiscal year 2022 Inpatient Prospective Payment System / Long-Term Care Hospital Prospective Payment System Final Rule, CMS finalized a change to their policy to extend NCTAP through the end of the fiscal year in which the public health emergency ends for all eligible products, to continue to mitigate potential financial disincentives for hospitals to provide these new treatments and to minimize any potential payment disruption immediately following the end of the public health emergency. If the public health emergency ends in May of 2023 as planned by the Department of Health and Human Services or HHS, discharges involving eligible products would continue to be eligible for the NCTAP through September 30, 2023, that is, through the end of fiscal year 2023. The NCTAP would expire at the end of fiscal year 2023 and no NCTAP would be made beginning in fiscal year 2024, that is for discharges on or after October 1st of 2023. Changes to NTAP policies for fiscal year 2024. To increase transparency and improve the efficiency of the NTAP program and application process, CMS is proposing to require NTAP applicants for technologies that are not already FDA market authorized to have a complete and active FDA market authorization application request at the time of submission of NTAP application submission, and to move the FDA approval deadline from July 1st to May 1st, beginning with applications for fiscal year 2025. CMS believes these policy changes would improve the completeness of submitted NTAP applications, allow for a fuller analysis and improved ability for CMS to identify eligibility concerns for the proposed rule, and allow the agency and the public to more knowledgeably analyze applications and supporting data to inform a final decision. Changes to the Rural Wage Index calculation methodology. CMS has taken into consideration recent public comments that have urged it to change its wage index policies involving the treatment of hospitals that have reclassified from urban to rural under Section 1886 D8 E of the Social Security Act, implemented in the regulations at Part 412, Section 103. After revisiting the statute and relevant court decisions, CMS is proposing to interpret Section 1886 D8E of the Social Security Act as instructing CMS to treat rural reclassified hospitals the same as geographically rural hospitals for purposes of calculating the wage index. Specifically, CMS is proposing to include hospitals with Part 412, Section 103 reclassification along with geographically rural hospitals in rural wage index calculations beginning with fiscal year 2024. That is, CMS is proposing to include the data of all 412.103 reclassified hospitals in the calculation of the wage index for the rural area of the state and the calculation of the wage index floor for urban hospitals in the state. Under the law, the area wage index applicable for any hospital that is located in an urban area of a state may not be less than the area wage index applicable to hospitals located in rural areas in that state. This provision is referred to as the rural floor. Physician-owned hospitals. For a hospital to submit claims and receive Medicare payment for services referred by a physician owner or investor, or a physician whose family member is an owner or investor, the hospital must satisfy all of the requirements of either the whole hospital exception or the rural provider exception to the physician self-referral law, commonly referred to as the Stark Law. To use the rural provider or whole hospital exception, a hospital may not increase the aggregate number of operating rooms, procedure rooms, and beds above that for which the hospital was licensed on March 23, 2010, or in the case of a hospital that did not have a provider agreement in effect as of March 23, 2010, but did have a provider agreement in effect on December 31, 2010, the effective date of such agreement, unless CMS has granted an exception to the prohibition on expansion. A hospital may request an exception to the prohibition on expansion of facility capacity using the process established in the calendar year 2012 Hospital Outpatient Prospective Payment System or OPPS and Ambulatory Surgical Center Payment System Final Rule. In the fiscal year 2024 Inpatient Prospective Payment System / Long-Term Care Hospital Prospective Payment System Proposed Rule, CMS is proposing to revise the regulations to clarify that CMS will only consider expansion exception requests from eligible hospitals, clarify the data and information that must be included in an expansion exception request, identify factors that CMS will consider when making a decision on an expansion exception request, and revise certain aspects of the process for requesting an expansion exception. Proposing to reinstate with respect to hospitals that meet the criteria for high Medicaid facilities, program integrity restrictions on the frequency of expansion exception requests, maximum aggregate expansion of a hospital and location of expansion facility capacity that were removed in the calendar year 2021 Outpatient Prospective Payment System / Ambulatory Surgical Center Final Rule. This is it for today. Just so you know that I am also creating another video on how CMS proposed rule for fiscal year 2024 impacts Hospital Inpatient Quality Reporting Program, PPS exempt Cancer Hospital Quality Reporting Program, and Long-Term Care Hospital Quality Reporting Program. So please stay tuned for that video too. If you found this information useful, please consider subscribing to my channel. Thank you for joining me today. Bye now.